Hello everyone, welcome to Healthcare and Beyond. Welcome back to Healthcare and Beyond. I'm Dr. Larry Rosenberg. We are here once again, but today we're not in the studio. We're at the very famous New York Academy of Medicine, which we're going to talk about here on lovely Fifth Avenue in New York City. It's an amazing building located in an amazing part of the city, and we got a very cool show for you today. Our guest, Lindsay Goldman, who works for the New York Academy of Medicine, is our guest, and we're going to speak with her in just a minute. I do want to read a little bit about her bio first here. Lindsay is currently the project director for the Age-Friendly New York City, a public-private initiative to improve the quality of life for older adults in New York City through changes to policies, practices, and programs. Lindsay has over 12 years' experience in program development and administration, social policy. She is the lead author of New York Academy's new report, Resilient Communities, Empowering Older Adults in Disasters and Daily Life. And this actually is the report that we're going to talk about today. It's a very thick, very comprehensive, very thorough, and actually a very interesting and readable report. And we're going to go through this in some detail with Lindsay today. Suffice it to say, there's an awful lot to talk about. Prior to coming to the New York Academy of Medicine, Lindsay most recently worked for the UJA Federation of New York, where she was responsible for strategic planning and allocations to programs and services agencies serving older adults in New York and in Israel. Lindsay also served as director of the Health Enhancement Partnership at Lenox Hill Neighborhood House, and received a Best Practice Award for her work from the National Council of Aging in 2008. She holds a bachelor's from Wesleyan University and a master's of social work from NYU. Lindsay, it is really a pleasure to have you here on the program today. It's a pleasure to be at the Academy. Thank you so much for joining us.
Thank you for inviting me.
You know, the New York Academy is one of those New York institutions that has a great history to it. I remember that many years ago when I applied for membership to the Academy, I sort of went through the history of it. And it's just amazing, you know, some of the things that the Academy has accomplished over its inception. Since its inception, I think it's, 1847. Mm-hmm. Among the accomplishments of the Academy is the help to establish the first Department of Health in the City Department of Health in the United States. Also, interestingly, helped to establish the first sanitation department, as well as the first medical examiner's office. So a real important part of the fabric of New York City, particularly a fabric of the medical community here. A lot of talks, a lot of lectures, a lot of conferences, a lot of activity takes place here at the New York Academy. So it's really a real privilege to be here, and really, really a lot of fun. Lindsay, I wanted to, before we get into the report, and we're going to talk about the report quite a bit today, because there's a lot there, there's a lot that's important, and there's a lot that's relevant to the life of New Yorkers, particularly in the wake of Hurricane Sandy. But I do want to talk a little bit about the Academy, just some of the things that the Academy has done recently, a little about the history, a little bit about the mission of the New York Academy. So what can you share with us a little bit, Lindsay, about the Academy?
So as you mentioned, the Academy was started in 1847 by a group of eminent physicians who recognized that the city's environment played a role in the health of the city's inhabitants. And so they recognized that there were reforms needed to modify the conditions that would in turn keep people healthier. And since then, you know, we've been working as a leader in urban health to address the most pressing health issues in New York City. And because New York City is really a global city, much of what we do gets replicated throughout the world. As you mentioned, the fellowship program, we have 2,000 fellows who come from a variety of health professions, and we have a center for the history of medicine and public health, a really wonderful library. But everything that we do is based on an evidence-based approach to policies and programs. So we have a couple of priority areas, one of which is healthy aging, which I'm going to talk to you a little bit about today. We also work on the prevention of chronic diseases, as well as the elimination of health disparities. And you know, whenever we're working, we're always doing so with the input of the people who our work will affect.
It's interesting to me that the academy here really, and from the work that I've seen over the years, tries to anticipate to a large extent, you know, some of the trends that are going to take place. I think I'll give you an example. This recent, I guess it was Bloomberg, the recent initiative, I would call it, or proposal by Mayor Bloomberg to try and eliminate the larger size soft drinks. Now that whole program came from work that was done at the academy, right? A lot of it? I think a lot of it was done here at the academy.
I believe so.
Yeah, and you know, I think to a large extent, the academy has its finger not only on the pulse of what's happening in New York City, particularly with urban health, but you know, what's happening to a large extent around the country. I mean, as you mentioned, New York is a global city. But it's not just a global city, it's a leader. You know, the medical institutions here in New York City serve as almost a paradigm for all the medical institutions around the country. It is the largest city in the world. It is probably medically, I would guess, the best funded city in the world. And it's not just, you know, medicine in New York City, but it's actually, you know, New York City as a cosmopolitan center that really, you know, allows it to serve as kind of a model for the rest of the world. The same problems that you have with, you know, the same urban issues that you get in New York City, you get everywhere else, but here on clearly a larger scale. You know, the things that happen in New York City are broadcast to the world all over the place because you have, you know, two of our largest newspapers in the world, or at least in the United States, English-speaking newspapers, the New York Times and the Wall Street Journal, both come out of New York City. All three television stations are based in New York City. So everything that happens in New York serves as a model, and everything that takes place in New York is magnified to the rest of the world. So being at the center of medicine, being at the center, perhaps the intellectual center, if you will, of public policy and urban health, the New York Academy has a real effect on what happens and has its finger very much on the pulse of what's happening in the world of healthcare. So it's really cool to be here. It's really interesting, and it's really a lot of fun. When did you start working here, Lindsay?
So I came here in the spring of 2013, and I originally came to work on this
project
research project that I'm going to talk about. But the project is part of Age-Friendly New York City, which is our partnership with the City Council and the Office of the Mayor to look at policies, practices, and programs across city life to see how they can be improved to maximize the social, financial, and physical participation of older people. And so through that, we had a platform that created a multi-sector age-friendly New York City commission, and this is really the way that NIAM works on all of its priorities, is to bring together people from, you know, different fields, different orientations, different sectors, to collectively problem solve when there are, you know, complex issues that need solutions developed. So that's something that's been in existence since 2007, when we worked to adapt the World Health Organization's active aging framework for New York City. And we've had some real gains on behalf of older people in that work. We've implemented some low to no cost solutions to really enable older people to become more active in their communities. We started by doing consultations with over 2,000 older people to ask them about their daily lives and, what did they like about their communities, what did they not like, and what were the barriers that prevented them from participating as fully as they might like. And then we worked with our partners to address those issues. So for example, we have a city bench program that put 1,500 benches throughout the city so that older people could stop to rest from point A to point B.
You never think about that,
we've
but
been
it's
told,
a simple solution.
and we've been told that the benches really enable people not only to increase their mobility, but also have served as to sort of catalyze relationships among older people who find themselves at the same bench at the same time every day. So that's one example. We also worked to change all of the bus shelters to become more transparent so that older people felt more comfortable sitting in them, adding seating. That was another initiative of Age-Friendly New York City. So we work across 8 domains, including the outdoor space and the built environment, as well as the workplace, housing, all of the domains that affect and are affected by older people.
It's interesting. I think I hadn't noticed, but I guess you're right. The bus stops are more transparent now. It's nothing that you really notice particularly, but now that I think about it, reflecting, I guess that's something.
Yeah, they changed all the bus shelters, and the great thing about that was that it didn't cost the city anything because the shelters were paid for by the advertisers that advertise on the side of them.
Very clever.
Yeah.
Very clever. We'll be back in just a minute. You're watching Healthcare and Beyond. Welcome back to Healthcare and Beyond. So let's take a scenario here. Let's imagine that you are an older American. Let's suppose that you live in New York. Let's suppose that you're in your 60s or your 70s or your 80s. Maybe you live by yourself. Maybe you live with your spouse. And let's suppose that you live on a high floor, let's say a 14th or 16th or 18th floor of an apartment building. And let's say that your health isn't too good. All right? Now suppose that a disaster happens. Could be a flood. Could be a hurricane. Could be a tropical storm. Could be anything that disrupts the life of the city as you know it. So let's say this happens. What do? Well, for one thing, the electricity's gone out. So you go to the TV, but there's no information on the TV because the TV's not working. You pick up the telephone to make a phone call, and maybe that's not working either. But maybe it is. But if it is working, chances are that the emergency communications are maximized. Everybody's trying to talk to somebody, so you can't really get through. You may have a cell phone. You may not have a cell phone. And if you do have a cell phone, it could be that the networks are jammed. Now, with the electricity being off, that means that it's dark. That means that there's no lights. You may have candles. You may not have candles. No electricity also means that the refrigerator's not working. All right? So your food supply is starting to dwindle. Okay? There's no heat in the building, or there's no air conditioning. And so that's starting to affect you. And if you're on medication, well, at some point your medication is going to run out. So what do? You look to your neighbor next door, and the neighbor might be able to help you, but chances are those neighbors who are a little bit younger than you may be preoccupied with their own issues, or they may have kids that they need to take care of. Okay? Your friends, and certainly, your friends are maybe in the same building, maybe not, but you have no way to get in contact with them. You can take the elevator downstairs, or maybe not, because the electricity's out. So you may walk downstairs 13 or 14 or 15 flights, but you know that when you get to the bottom floor, you're going to have to walk up. And if you're in your 60s or your 70s and your heart isn't too good, you don't want to have to face the prospect of climbing back up again. And when you get down to the bottom floor, what you find is nothing. No security, because probably the people who are doing the security work are back home taking care of their own families. Is it a nightmare? Yeah. Is it a scary situation? Absolutely. But this was the reality that older Americans faced just recently with Hurricane Sandy. And it's this reality that set in place this project, which Lindsay has been spearheading for the past year, Resilient Communities, Empowering Older Adults in Disasters and in Daily Life, an initiative of the New York Academy of Medicine, which we're going to talk about today. Lindsay, there's an awful lot that went into this report, and clearly it speaks to a very fundamental need in our ability as Americans, and particularly as New Yorkers, to take care of our aging population, especially in the crisis. And New York has had, a number of crises recently, not only the recent Hurricane Sandy, but of course, the unfortunate incidents of 9/11. How did the project get started? What led people to come to the conclusion, or perhaps shock them into the realization that we really needed to do something for our older Americans? What is the genesis of the project, if you will?
Right. So, as you mentioned, Hurricane Sandy was very difficult for a lot of older people, not just in New York, but in all of the affected localities. And 25 of the 44 people who died in New York City were older adults. They died primarily by drowning at home in Staten Island and the Rockaways. And though there was a mandatory evacuation, the majority of people, including older adults, chose to shelter in place for various reasons. After the storm, storm is often a very good opportunity to conduct some research, to understand, what could have been done differently to try to assure better outcomes next time.
Right.
And so immediately after the storm, about 2 weeks after, the Assistant Secretary of Preparedness and Response, Dr. Nicole Lurie, asked the New York Academy of Medicine and the Institute of Medicine to convene a meeting of healthcare leadership from the public and private sector to determine what those immediate research priorities would be. And one of them that came out of that meeting was how were vulnerable populations affected by the storm, and how were they assisted during the storm?
So it was, and she was a federal assistant secretary?
Yes.
So assistant secretary for
Preparedness and Response,
Okay.
which is under the Department of Health and Human Services.
So it's a fairly high-level government initiative.
That's right.
Yeah.
So that's how it started, and then we were lucky to have two private foundations, the New York Community Trust and the Altman Foundation, step up and support a year-long study of older people in disasters with a special focus on Hurricane Sandy. We chose older people because healthy aging is a priority of the New York Academy of Medicine. We had this platform of age-friendly New York City that we could build upon, but also because older adults share many overlapping concerns with other populations, though they also have their own issues that are unique to them, that are a function of age and life stage. So I think that the recommendations that we came up with are applicable to older people, but also to other populations like younger people with disabilities. So from that meeting, we determined the scope of our work, and we started by convening a high-level Older Adults in Disasters Policy Advisory Committee that oversaw the work from its inception. and provided guidance on every step of the process, including all of the recommendations that came out of it.
Now, I just want to interrupt you here, and the reason I'm doing so is who was on that who was on that committee?
So similar to our age-friendly New York City Commission, this committee was a public and private committee that consisted of representatives from various government agencies like the Department for the Aging, the Department of Health and Mental Hygiene, the Health and Hospitals Corporation, the New York City Housing Authority, as well as many private sector representatives, such as those from community and faith-based organizations that were on the ground during the storm helping to meet the needs of older people, representatives from the housing sector, as well as the business sector. So, we all came together to collectively strategize, how we could do things differently next time. Because as you said, New York City has had many disasters over the last, 12, 13 years. Starting with 9/11, then we had a blackout, we had 2 major heat waves that killed some older people, we had Hurricane Irene, we had Hurricane Sandy, and unfortunately, despite efforts that were made to safeguard against these kinds of things, in each case we saw the same conditions arise. Older people, tens of thousands of them trapped in high-rise buildings or private homes without access to food, water, medical care, medication, heat, air conditioning, as you said. So, we needed to figure out what's missing here and why have our efforts been largely unsuccessful thus far.
So, and the reason that I asked you about who participated in the committee is because it seems to me that I guess a lot of the model for a lot of the programs that the New York Academy has involves bringing people from these very disparate but important organizations together, get some funding, and then develop an initiative. So it sounds to me like the kind of work that you're doing here, the kind of work that you've done in this particular project is emblematic, if you will, or typical, perhaps, of the kind of work that the New York Academy of Medicine does. Is that a fair statement?
That's absolutely true, and I would say that coupled with always going straight to the source. Right. So speaking directly to the people who were affected by the storm and the people who helped older people during the storm. So it's a two-pronged approach. It's the multi-sector collaborative and going right to the people who experienced it.
Interesting. Now, clearly there's a ton of work that you put into the project, and the conclusions that you drew, as we'll come to in a little bit, are far-reaching and pretty interesting. How did you start with your research? Did you look at literature that has been written? Did you interview people? Did you do focus groups? Did you put together seminars? How did you gather all this ton of information that you're putting together?
Well, we did all of those things that you've just mentioned. We started with a literature review to see, what research had been done in this area, and we found 2 things. One of which was pretty expected, that older people are maybe more vulnerable to disasters because of their predisposition to, chronic health conditions, to mobility and cognitive impairment. They are often more socially isolated than younger people, or more at risk of social isolation. They may have certain financial limitations if they're on a fixed income. And so for all these reasons, older people may, in fact, be more vulnerable in a disaster. At the same time, there is literature to support that older people may be more psychologically resilient following a disaster than their younger counterparts. And this is often attributed to, their increased life experience, which may have some sort of protective value. So we heard a lot of, whatever this storm is going to be, it can't be any worse than what I've lived through already.
It was very interesting, and reading through it, I found that to be one of the interesting things of the report. And there was a lot that was sort of counterintuitive, but when you think of the older Americans being the ones who are most vulnerable and the ones who are most likely to suffer, and the ones who are most likely to have a difficult time, quite counterintuitively, it turns out, not counterintuitively, quite to the contrary, it turns out that those are the very people, who are the best equipped to deal with this situation, because of, to a large extent, what they've been through.
Right.
One of the things that I thought was interesting in your report that you mentioned, that a lot of older people were unwilling to leave their home. And one of the reasons that was given, and historically this is very interesting to me, is that a lot of people, or a lot of the older Americans, particularly those who are well up there in 70s and 80s, carry with them the experiences of Nazi Germany, carry with them the experiences of Russia, carry with them the experiences of other countries and other situations in which they have been forced out of their homes, or left their homes, or evacuated their homes, and that itself has really been a disaster. So for them to cling on to their homes, to stay where they are, was also, and I thought that was a very interesting observation that you made in that report about that.
Disasters can evoke past trauma, especially among older people who, as you said, may associate, evacuation with, war and displacement, and and we heard a lot of that. You're also dealing with cultures that may have an inherent distrust of government, and so I think that when we think about how we talk to older people about the need to evacuate, because the reality is the only way to prevent drowning at home is by evacuating.
Right. Well, in that situation,
right?
It's clear.
So when we think about talking to older people about the need to evacuate, those conversations, because they are so loaded, those conversations can't happen during a mandatory evacuation. We need to start talking about it now under routine conditions and recognize the value of home for an older person, which may be a little bit different than for a younger person. What does it mean for an older person to have to leave their home, even if it's just for a day? So that was something that we wanted to look at, and so we did do focus groups. We did focus groups with 138 people, older people who were 60 plus who had been affected by the storm, as well as people of any age who assisted older people before, during, and after the storm. And we did these focus groups in 5 seriously affected communities. We did them in Mandarin, English, and Spanish. And if we had had more time and money, we would have done one in Russian as well. But the thing to know about the areas that were so affected, these evacuation zones, they do have higher levels of poverty, of disability. There are larger numbers of people in these areas that don't speak English, and larger numbers of older adults. So, when we think about why we saw the conditions that we did, we need to think about, who lives in these regions that are vulnerable.
It's a large effort. It's a big effort.
Yeah. We also conducted key informant interviews with people from a wide range of backgrounds who had something to say on this topic. We spoke to emergency management professionals from across the country. And, we made a real effort to talk to people who were not part of the formal emergency management sector, but who were really essential in helping older people to meet their needs. Then we analyzed a lot of the data that was collected following Hurricane Sandy through canvassing efforts, and we did some mapping of areas with large concentrations of older people overlaid with the evacuation zones.
There were quite a number of conclusions which you drew from the report. I found there almost to be sort of two different areas of focus within your conclusions. One was sort of looking at things from an older person's perspective, and the other was, of course, looking at the various agencies and the various services that reach out to these individuals. One of the things that you mentioned was that the older individuals themselves, at the time of Hurricane Sandy, had difficulty connecting with those resources. And I'm wondering if you could just talk about a little bit, why did they have difficulty? Was this something that, was it something that perhaps could have been dealt with beforehand? And I guess the reason I say that is because, certainly there were a lot of lessons learned from 9/11, and there was a lot of stuff done from, a lot of initiatives that took place after 9/11. And perhaps, this was something which was initiated, or I just wonder a little bit about that. But how did that particular, talk a little bit about that particular finding?
So when we think about older people in New York City, we're talking about 1.4 million people of 8.4 million.
Okay.
And largely, this group is independent, and they take care of themselves and manage their health conditions without a problem, assuming they have access to the various systems and services they need, like transportation, communication, electricity, and elevators.
Oh, sure.
Right?
Sure.
And so because these people are doing just fine under routine conditions, they're often unconnected to the kinds of organizations and services that would be able to assist them during emergencies, which means that while the emergency is occurring, they have to figure out where they're supposed to go for help. So that's part of it, just that, most older people are very independent, and therefore, they don't need to be connected to services.
Lindsay, we're just going to take a break for 1 second here. We'll be back in just a minute, Healthcare and Beyond. Welcome back to Healthcare and Beyond, here at the famed New York Academy of Medicine with my guest, Lindsay Goldman, today. Lindsay, just to continue our conversation about older folks and dealing with disasters, one of the points that you made that I thought was very interesting was that the very fact of these older folks being so independent means that they were not so connected with the typical resources that people are when they're more dependent, but which works well for their life in peacetime, if you will.
We call them temporarily vulnerable.
Temporarily vulnerable. But of course, when crisis hits, because they don't have those connections, it sort of works against their favor, if you will. There were a couple other things that I found interesting in the conclusions. And again, we're talking about the report here, Resilient Communities, Empowering Older Adults in Disasters and Daily Life, the project that Lindsay has been working with the New York Academy of Medicine for a year. This very, very fascinating, very comprehensive report. The other thing you mentioned, Lindsay, was that there were also some other issues lacking. There were some, and then this is sort of from the service provider side, if you will, the people who are empowered with taking care of other people, the emergency management situation, the organizations, the community service, the nonprofits. Specifically, you spoke about a lack of communication resources. You spoke about a lack of technology resources, and you spoke a little bit about support networks. Elaborate on that a little bit, if you will, Lindsay, about those deficiencies.
Underlying all of those issues is the fact that older people were not consulted about what they might need during and after an emergency and how they would get those resources. And so because older people hadn't been consulted the way that they needed to be, the very services that were intended to assist those who had been affected by the storm were often inaccessible or inappropriate for older people. So that, for example, if an older person was, on the 22nd floor of a building and all of the food was delivered to the lobby of that building, you needed an army of volunteers to go up and down with all of that food to ensure that everybody was fed. But, the response was really a very organic one in that the majority of people were helped by friends and family, which is not, or neighbors, which is not unusual in disasters. And 73% of the people we spoke to who were part of the response were from the affected community. So, everybody did the best that they could with the resources that they had. But those organizations and those people who were on the ground in those communities were not being coordinated in any way. And so you saw redundancies and gaps in service delivery. So some people got, 3 knocks on their door, and some people never got a knock on their door to see if they were okay. And I think that, when we think about who are the people who respond in a disaster, time and again, it's neighbors, friends, and family. And so those are the people who need to be incorporated into the city's emergency plan to ensure that resources are distributed equitably and efficiently. So that was, one of the issues that we faced. And I think that, the other issue was a lack of comprehensive planning to maintain the health status of older people. So that, when we think about what are the things that older people need in order to stay healthy, well, 80% of older people are on some kind of regular medication. So this is something that we need to plan for those people who require in-home services in order to meet their basic needs and to accomplish their activities of daily living. We need to plan for the continuation of those services. And when we don't, we see the exacerbation of chronic conditions and the emergence of new conditions among older people. And we see people going to the emergency room for things that they really didn't need to go to the emergency room for, but they believed that that was, the only alternative. For things like, medication and oxygen and dialysis, all things that can be treated outside of the emergency room if there's adequate planning.
It seems as though the conclusions that you've reached are almost in line with what, your intuitive understanding would be, namely that, if you want to find out what is going to be an issue with somebody, well, go ahead and talk to them. So speaking with the folks, even though I guess it was an expensive lesson to learn, it's if you want to call it that, backed up by evidence now that you really should speak to the people who are at risk and see what their needs are, which is which I guess is one of the important research lessons, if you will. And then, of course, the other one, which is again sort of in line with what you would expect intuitively, is planning is a good idea. If you're going to move forward with trying to maximize or trying to find the best solution to dealing with the problems that these folks face, when they get into a crisis situation. There's in the report, and it's a big report, you sort of divide it nicely into sort of introduction, and then you go into your research, you present the conclusions, and then finally the recommendations. So if it's okay with you, Lindsay, I want to just turn to the recommendations a little bit, because these are really sort of the the sort of take-home points, if you will, the reason why the project was put together in the first place. Tell me what, in your opinion, were the most important recommendations that you drew from all this work?
So with these recommendations, we're really calling from a paradigm shift, one that has traditionally focused on individual preparedness to one that acknowledges that the full community has a role to play here. So the reason that we've seen the same conditions time and again, despite lots of energy, time, resources invested in preparing, is because we have focused on checklists and go bags that require not just older people, but everyone to amass a whole lot of stuff. And the sort of conventional wisdom, which is really not grounded in evidence that you'll be better off if you do these things, but conventional wisdom says, you know, you prepare for 5 days, you have X number of gallons of water, you have, you know, the batteries and the flashlights, and you have 5 days worth of medication, right? But so it is really impossible to prepare every person for every possible disaster scenario. You can't predict the nature and severity of a disaster. You can't predict whether 100 pharmacies will be destroyed, as they were during Hurricane Sandy. And so rather than encouraging people to get stuff, which older people, as well as other vulnerable populations, face a lot of barriers in acquiring all that stuff, whether it's financial, storing the stuff, carrying the stuff, right? And then what happens? You know, you have stuff for 5 days. The emergency lasts 6 days. Emergency lasts 28 days. Emergency lasts 6 months, where some people still had no power in the Rockaways. You know, what's that stuff going to get you? It's more important for the community to know how to adapt to rapidly changing conditions. And so that is the sort of underlying premise of the recommendations that we have put forth here, which call upon all of the various sectors to consider how older people will be affected, how their needs will be met, and how their assets can actually be harnessed to meet their needs in a disaster. So for example, when we think about where to start, housing really needs to be the locus of disaster preparedness, right? Because that's where people are. That's where you can reach them. And you know, I think a lot of building owners and property managers, they had evacuation plans, but they didn't think, what will happen if 90% of my building refuses to evacuate? What will I do then? And so they simply had not planned for that. It's really critical for building owners and managers to know who's in their building. What are their vulnerabilities? Do they speak English? If they don't, what language do they speak? What reading level do they need to understand something? And if they're not going to be able to get down the stairs, in order for these people to maintain situational awareness and make the best possible decisions for themselves, they're going to need information delivered to every floor of that building. And so it's a matter of understanding, you know, who lives there. And there are absolutely going to be needs that exceed the capacity of a landlord, and that a landlord is not the appropriate person to have to meet those needs, right? But so we're calling upon landlords to think about, you know, what are the partnerships you can make within the local community, with local businesses, with community and faith-based organizations that will be able to deliver the services that your tenants may need.
So you really, I mean, it sounds like you're trying to more or less empower them, more or less encourage them, or almost demand, if you will, that they take on responsibilities, or at least an awareness, but a sort of a preparedness responsibility that they may have not had to take on before.
That's right.
So that's kind of, instead of saying, you know, you and you and you, make sure you get all your candles and all your food and all your peanut butter and all your raisins and all your batteries in line. It's fine that you do that, but, you know, let's set up an organization which will empower those who are responsible for all you people. To do something. So that is, I mean, that is a kind of it's a different way of thinking.
No one is arguing that it is a good idea to get water and flashlights. We're simply saying that's not all we need to do, right? and that it's not just on older people themselves to solve this problem.
Yeah.
Rather, this is everyone's problem. It is everyone's problem when older people flood emergency rooms for things that they don't necessarily need in a disaster.
Sure.
So, that's where, we get to the idea that we need everybody involved here. And we need to build the capacity of people to respond. So, we need to train our first responders on how to effectively talk to older people and what it means for an older person to have to leave their home and why they may be so resistant to doing so. And I think, the more that people understand where older people are coming from and what the best way to communicate with them is, the better we'll all be. I think that kind of training would also benefit volunteers who go into older people's homes and provide assistance in a disaster. It's very important that we speak to older people and we understand where they're coming from.
Now, in the report, you mentioned there's a lot of recommendations. There's maybe about 13 or 14 different.
There's 12.
Is it 12?
Yeah.
Okay. Well, 12 and 13 or 14 are numbers that are close to one another. I think the older I get, the more I lose focus on stuff like that. But 12 is good. 12 is good.
Yeah. We're not allowed anymore.
Thank you. But in among a number of those recommendations, this idea of creating I guess you call it a locus.
A hub.
But almost a hub.
Yeah.
Which involves, emergency management people, which involves landlords, which involves community, religious figures, which involves nonprofit organizations. The recommendations involve a lot of different people and suggest an awful lot of planning. So, given that New York City is, 10 million people in New York City?
8.4.
8.4 million people in New York City, with a huge number of buildings and people and landlords, just from a really practical standpoint. All right, let's say I'm living in the South Bronx, or I'm living in Bedford-Stuyvesant, or I'm living in Staten Island. How does this break down in real life? What in your ideal situation would take place in a community in order to bring this together? What would take place to keep it together? What's a sort of a real life scenario with a timeline as to how one of these hubs would form?
Well, I think a hub can be, really a one-stop shop for preparedness and response. So it can be housed in any kind of local existing institution, like a school or a restaurant, and these hubs, by the way, arose organically during Hurricane Sandy. And so if we think about how can we consciously create something now that will be able to help us later, we'll be ahead of the game.
Right.
And the thing about it is, while New York City is very large and has millions of people, we're also very much a city of neighborhoods.
That's true. Yeah.
And the whole city is organized, right? We have 59 community districts. Each of those districts has a community board. Right. So I think that the more we use existing structures, and the more we incorporate preparedness into activities of daily life, the easier this is. This becomes a lot more manageable to think about. And so, if there's one community board I know of now that's trying to sort of actualize this. And they're thinking about, what are the institutions that people often go to? Is it a library? Is it, the cafeteria of a hospital? How can we be more creative in our use of communal space so that the community can come together, plan, and that people who don't necessarily need anything now will know where to go should conditions change?
So, within that structure that you mentioned, within that hub, whether it be, whatever it may be, a cafeteria, a community center, a school, maybe a religious institution. Clearly there has to be some group of people who are going to take responsibility. But also it sounds like, which makes a lot of sense to me, is that as part of the normal course of affairs, the normal course of events, the normal course of things that take place with community board meetings, with announcements, with initiatives, that this crisis planning be incorporated as part of the normal course of daily life. And it seems to me that's kind of what maybe, it seems to me that's what the report seems to be speaking to. One of the major, I wouldn't call it a straight out recommendation, but almost one of the premises of your study. Is that a fair statement?
Yes, that is absolutely true.
Yeah.
And I think that healthcare has a really critical role to play here, especially when it comes to risk communication with older people. I think that a lot of times we think of risk communication. We think the mayor on TV saying you all need to evacuate. Here's what's coming, or the Office of Emergency Management sending around these checklists that I mentioned. Urging older people to be prepared, but older people, especially those that are not connected to services, that don't go to senior centers, that don't necessarily know about all of this stuff, where are they going? They're going to their doctors.
Yes.
And what do they need in an emergency? As evidenced by all of their ER visits, they need medication, they need durable medical equipment, that kind of thing. And so to me, it's really incumbent upon the doctors to speak with their patients when they're prescribing a medication or instructing someone on how to use a particular device, to also have a conversation around, what will you do if you can't take these pills? Is there some alternative intervention that can be used? Can you change your diet? Let's think about the reality that, in our region, we're going to be experiencing more frequent and more severe disasters, which may impact the power. This will, in turn, affect your ability, or may affect your ability, to access your healthcare professional, your medication. Let's strategize together to figure out what is the best decision for you in that circumstance. Because I think that a lot of people don't understand when the mayor is on TV saying, this is what we're expecting, you need to evacuate. People are not necessarily making the connection, how will this affect me personally? And I think that doctors can play a really big part in helping people to understand that and make good decisions for themselves.
Yeah, I think you mentioned an interesting point that older folks, particularly, I think you mentioned like 80% of older folks see the doctor. I mean, the number's probably higher than that.
80% are on medication, regular medications. Yeah, at least one.
And I think older folks do spend a lot of time at the doctors. Some for good reasons, because they're taking care of themselves. Some because they haven't been taking care of themselves, and some because it's just the nature of, what happens when you get older is you see the doctor. But I guess I had not thought of that as a vehicle for communications and a way to get the message out to these folks. Because sure enough, they spend a good amount of time in their doctor's office. Were doctor's offices and the nurses and the other people who work in the offices able to kind of get this information out to them, not only would it be a way of them to getting the information out, but the very fact that they're in the doctor's office stamps it with an almost kind of an authority. As here's somebody whose job it is to take care of you, we're telling you that this is important, in the same way that nutritional recommendations are taken seriously by patients because it comes from their doctor's office. So that's
exactly
a really
right. It has a much different tone when it comes from Dr. So-and-so. Well, the CDC says you should evacuate because otherwise you're at risk of drowning at home. There's no connection there.
Lindsay, have you seen what have you seen so far? I mean, this report came out in, was it this year, 2014?
In July.
It was in July of 2014. So I mean, it's obviously it's a new report. But have you seen some of these recommendations started to take hold?
We have, and it's really exciting. Local 32BJ is the Building Service Workers Union here in New York City. They have 55,000 members, and they were on our advisory committee, and they've created a training for all of their members, porters, maintenance men, doormen, and it's a training that instructs these workers on, how to respond to a disaster situation from both a, physical resilience perspective to the social resilience perspective, which is really fabulous. And they've incorporated a module into this training on the needs of older people in disasters. So they're really trying to build capacity among their membership.
So that's good.
Which is really fabulous.
That's great.
We've also been working with HUD at the federal level, as well as the regional office, to increase the resilience of affordable housing within New York City. And so, they're very much on board with making some changes and helping to build capacity within those buildings, which is where we saw, a lot of the older people trapped, as well as in the New York City Housing Authority properties. They're also very committed to changing the way that, they do business during an emergency to ensure that, they can better either meet the needs of their tenants or partner with some other organization to meet the needs of the tenants. So I think, there definitely has been some traction. I think there's a recognition that, doing the same thing over and over again and finding that it doesn't work is not going to cut it anymore. So we need to really change our orientation and sort of rethink some of the strategies that we've been using to prepare people.
Interesting, Lindsay. It's interesting and it's important. We have a large number of people here in New York who are vulnerable, and I think it speaks well not only of the New York Academy, but I think it speaks well of our various institutions, our government institutions, our nonprofits, and our government, quite frankly, that's taken the initiative to take a look at the problems that have resulted as a result of Sandy and really try and prepare for the next whatever may happen. Clearly we could have a hurricane at any time, or another disaster could strike. And being able to prepare for it, being able to try and limit the amount of damage that takes place and disruption that takes place in the lives of these older folks and help them to deal with it is an important part of our life and an important civic responsibility. We're here at the New York Academy of Medicine. Lindsay, I want to thank you for talking to us. We've been speaking with Lindsay Goldman here, who is the author of this very interesting and very important report by the New York Academy of Medicine. And we've had just a lovely time speaking. I want to thank Kiri Oliver for having us and the New York Academy of Medicine for letting us interview in this just amazing building, this beautiful library or conference room, I guess it is. I'm Larry Rosenberg from Healthcare and Beyond, and we will see you next week.